Hi everyone, and thanks Andy for the introduction. So my name is Bayliss, and I'm a final year anaesthetics and RCM registrar in Leeds. I fly at Links and Knots Air Ambulance at the moment. And so I was asked if I could talk about videolaryngoscopy, and I'm going to talk about it in the context of emergency intubation, mainly in pre-hospital emergency medicine. And when I was thinking about what I was going to talk about, I was giving some thought to kind of direct-to-video productions. So low budget, controversial, appeal to quite a niche market. And that's very much how videolaryngoscopes appeal to me in kind of the initial phase of my training. So a specialist tool, rarely used, controversial amongst those who'd advocate that there's nothing more effective than a Mach 4 and a strong left arm. Higher cost than our standard practice, and yet still pretty underdeveloped. There's been a lot of progress over the last decade since I became an anaesthetist. I'm going to take you through some of the issues that have pushed its development, introduce the kind of current range of devices, and discuss kind of the available evidence and consensus opinion around their use. So before we start talking about videolaryngoscopy, we kind of need to have a little think about how it differs from direct laryngoscopy. So in direct laryngoscopy, what we're trying to do is we're trying to align these three axes, so the oral axis, the pharyngeal axis, and the laryngeal axis, so that we can see directly into the glottic openings, the opening to the top of the trachea. And the way that we do that is we optimize the patient's position. So we get their head extended, we flex their neck at the lower part of their cervical spine, we open their mouth wide, and then we try and move some of the soft tissues out of the way with a direct laryngoscope so that we can see in. And clearly, in some patients, that's going to be easier than in others for a variety of kind of patient factors or incident factors or equipment factors. Videolaryngoscopy, by contrast, what we're doing is we're trying to see around that corner. We don't need to align those axes. So we can either put a small camera on the tip of our device, or we rely on lenses or fiber optics to bring the image towards us. And then that normally gets relayed to an electronic screen that we can see, so that then the operator can intubate the patient. And this image gives an idea of what we're actually looking for with a videolaryngoscope. So if we look at A, first of all, so that's our direct laryngoscope. So we've got the tip of the laryngoscope in the vallecula, and we've got direct line of sight to the glottis. When we compare that to B, so that's a Macintosh geometry videolaryngoscope. So again, we can do direct laryngoscopy. We can still put the tip of the laryngoscope into the vallecula, lift the epiglottis and see the glottis. But also we've got, because of where the camera is positioned near the tip of the laryngoscope, we've got a view that goes more anteriorly. So we can actually intervene in things that we can't see. So we can actually get a tube or a bougie round the corner beyond your direct line of sight. And that's how videolaryngoscopy is kind of more useful in terms of getting a view. And if you look at C, we've got a hyperangulated type device. So what you can see from this is, so this is designed for a patient who's got very anterior larynx or has some kind of anatomical abnormality that makes it very challenging for us to intubate them. So thinking about things like poor jaw movement, short jaws, short necks, immobile necks. So thinking about people who've had their spine immobilized or they've got really prominent teeth. And you really can't do direct laryngoscopy with these hyperangulated blades, but you can see much further around the corner, so you can intubate patients who would potentially be unintubatable with a standard geometry blade, especially a direct blade. And when we think about what those pictures actually look like, so on the left we've got a image of direct laryngoscopy. So obviously you're going to be a little bit further back than that because that camera's right at the patient's mouth. So thinking about being probably, an arm's length further away than that. So you can see that you've got direct view of the epiglottis, which is marked an E, and then you can just see the arytenoids and the trachea that's marked with a T. And you're going to get a bougie in that hole, and then you're going to get a tube that goes through as well. And as you advance that tube, you're inevitably going to lose sight of the trachea itself as you intubate the patient. Whereas in comparison, when we've got a videolaryngoscope, so that's what you can see on the right-hand side, it's the CMAP type of videolaryngoscope. You can see that we've got an excellent view of the glottis. Actually, that view is probably better than what you need in order to actually intubate the patient. But you'll be able to see your bougie and your tube come in from the right-hand side of the picture, and you'll be able to visualize it as it passes into the glottis. But what problem are we actually trying to solve here? So pre-hospital intubation is obviously by its nature going to be really challenging. So our most common indications for intubation in the pre-hospital environment are going to be trauma and out-of-hospital cardiac arrests. So that can be either during the arrest or anaesthesia following the arrest if the patient remains unconscious. The trauma patients are going to be difficult to intubate because they've got their cervical spine immobilized. They might have traumatic injury to their airway at any level. There's often going to be blood or soot or vomit within their airway. And patients who've had cardiac arrest in the community likewise are going to be challenging. They'll often be intubating on the floor, we've got limited access to the patient, limited ability to optimize the position of the patient, thinking about moving their head and their neck. From experience, they're also more likely to be overweight, and they'll almost always be airway soiling from gastric contents. So these are difficult airways in the pre-hospital environment. And NAP4 was a real sea change in the way that we approached airway management in the UK. So this is a national audit project of the Royal College of Anaesthetists. So looking at complications of airway management in anaesthesia. So that's elective and emergency anaesthesia, but in anaesthesia in the UK. And the relevant issue for us is that it highlighted the relative danger of intubation outside the setting of the anaesthetic room. So thinking about emergency department intubation, critical care intubation, there's a higher rate of adverse events, and the morbidity and mortality associated with those events was also higher. Now, that's partially a result of increased acuity. You have a limited ability to formally assess the patient before you intervene and anticipate those airway management difficulties, and that kind of unplanned nature of the airway intervention that happens in those areas. But there are lots of system factors that were highlighted as well. So thinking about less experienced personnel, reduced availability of kind of advanced airway equipment, and a failure to use those sort of safety enhancing processes that we've been keen to build into pre-hospital care in the time since, things like pre-intubation checklists. Now, this is obviously an observational study of in-hospital practice, but you can see how those system factors translate into our work beyond the hospital doors. And unfortunately, there are very real-life consequences from the difficulties that people have with airway management. So both of these patients died from unrecognised esophageal intubations, and in both cases, the anaesthetist thought that there was an alternative cause for the inability to ventilate the patient rather than an esophageal intubation. Unfortunately, by the time that it was recognised, there was sufficient damage from hypoxia that the situation was irrecoverable. And those both have occurred since the publication of NAP4, despite the many improvements that we've made to our care of patients in hospital since that was produced. These are obviously particularly well-known cases from anaesthetic practice, but I'm sure you'll be aware of similar cases in your own organisations. How does that translate into our pre-hospital practice? Well, in 2013, there was a pre-hospital study. And so this is one ambulance service and one enhanced care team. But when the enhanced care team arrived, 11% of the patients that had been intubated had an unrecognised esophageal intubation. Now, hopefully that's reduced for a lot of reasons, but there's an argument that that's less likely to occur with a videolaryngoscope, where you virtually always have a good view of the glottis, including as you pass the tube into the glottis itself. We've already discussed some of there's some benefits kind of from an anatomical point of view to improve our chances of getting a good laryngoscopy view, and reducing the risk of unrecognised esophageal intubation. So we've kind of already discussed that, but there are other benefits from the use of videolaryngoscopes. So there's you can have shared situational awareness between the anaesthetic team. So that might be between the anaesthetic assistant and the airway operator, or it might be between the airway operator and supervisor. So allows a supervisor to provide guidance to a more junior colleague or reassure themselves that all is well. Some pre-hospital services have kind of taken this one step further, and what they do is they're routinely using a videolaryngoscope, but turning the videolaryngoscope screen away. So using it for direct laryngoscopy, and so there's that shared situational awareness with the airway assistant. But then if there's any challenge with the intubation, then they can just turn the screen around and they've instantly got a videolaryngoscope in use. The only risk of that approach is obviously, you can see one of my colleagues demonstrating really well here, is that one of the roles of the airway assistant is to provide the kind of global situational awareness of what's going on. So as you can see here, Chris has got his eyes really firmly focused on the monitor, and he'll also be aware of what the other people on scene are doing. Whereas Alan, who's just performed the intubation, while he was doing the intubation, will very much be task focused on that. And the risk is that you then get the whole anaesthetic team being task focused rather than just the intubator. The other benefit of that use of direct laryngoscopy first line, even though you're actually using a videolaryngoscope, is that it reduces one of the perceived risks of videolaryngoscopy, which is the skill fade and loss of direct laryngoscopic skills. And that's especially concerning clinicians that are performing quite a low number of intubations per year. There are obviously some other risks associated with it. So there's issues related to the camera. So these images are all taken from the Sydney Hems Airway Registry, and that QR code in the bottom right corner will take you to it if you have an interest. So in the image at the top left, you can see that the camera's become fogged, and that's obviously just on insertion into the airway. And actually, most of the devices have kind of internal ways of getting rid of fog off the camera lens. But even if you only lose it for your image for a couple of seconds, that will still impact on what you're doing. There's also issues related to getting blood or getting vomit on the camera, and that can obscure the view to a point that you actually can't proceed with videolaryngoscopy. You can obviously mitigate against that with cautious use of the blade itself, and judicious use of suction to make sure that you don't end up getting anything on the camera. But obviously that's much more difficult in a patient that's receiving chest compressions. In the bottom left, you can see an airway that's contaminated with soot after an inhalational injury. And that can make it very challenging to identify the airway structures. And that can actually be more of a problem with videolaryngoscopy, where some of the devices have relatively less bright bulbs compared to most direct laryngoscopes. So this shows you, for example, the difference between the kind of brightness that you see. So you can see that the glide scope that's on the left-hand side, you can see that that's not as bright as the direct laryngoscope or the CMAC. So thinking about your routine use of it as kind of trying to do direct laryngoscopy with the same devices, they might not perform necessarily as well. But obviously you can see that the CMAC is actually is quite effective. The other issues is kind of outside the hospital, kind of glare of the sun or vehicle lights can make the view more difficult. So that can either be because it just makes it difficult to see the screen, or because you're getting reflections off the screen that are becoming challenging for you. And one of the things from an organisational perspective is that you do need to train with these devices. So you can't give these devices straight to somebody who's experienced with direct laryngoscopy and expect them to perform as well with a videolaryngoscope as they will with a direct laryngoscope. The physical technique and the tube delivery is actually different, and probably one of the pitfalls is trying to use them just like a direct laryngoscope. You often get a description that somebody's got an excellent view of the glottis, but then they've been unable to pass the tube because they just can't get around the corner. and that's a failure of training. And the way that you overcome that is that actually you just need to be a little bit further away from the glottis than you would expect with a direct laryngoscope. And that gives you a better view, a less acute angle to get the bougie or the tube around. So what devices are out there at the moment? So on the left is the first video laryngoscope that I've ever used, so that's an AirTrack. So it's a single-use device, although they have now made a reusable version as well. And it uses a series of prisms to convey an image from the tip of the device to the operator. And then either you can look directly down the device, or as here, there's a camera attachment that fits on the top of the device. It's a channel device, so the tube fits down the side, as you can see, which means that you don't need a bougie or a stellette to assist it. And that guides it directly towards the visual field of the device. And they have kind of a range of patient sizes. The optics, as you'd expect with a disposable device, are not quite the quality of some of the more expensive devices. But I think its main drawback is that its action is completely different from a kind of standard geometry laryngoscope. So if you insert it and get a good view, then that's great. You can stick the tube in and all as well. But if you don't get a good view, then actually optimizing your view, if you've not used it very much before, is going to be quite challenging, just because it is a completely different action from a normal laryngoscope. On the right, we've got the iView, which again is a completely disposable device. So it's a much more kind of standard Macintosh geometry design. Again, because it's disposable, the optics aren't amazing. When you kind of compare it to the reusable devices, it only comes in one size, which is roughly similar to a Mac 4 blade, which does mean that it has reduced utility in kind of your smaller patients. And they don't offer any hyperangulated options either. So personally, my feeling is that it doesn't offer much more than a kind of standard Mac 4 laryngoscope. And both of these disposable options have really low setup costs, because the cost of individual devices is quite low. But obviously, if you're going to start using them frequently, then the cost is going to stack up pretty quickly. The more expensive devices all have kind of a varying degree of disposable components. So on the left is the McGrath Videolaryngoscope, which is probably the most ubiquitous one, certainly in hospital. It's got pretty good optics. It's relatively low cost, so it's about £1,500 for the device, and it's about £6 per intubation. There's a full variety of sizes of blade, so you can go from kind of very small children all the way up to adults, and there is a kind of proprietary hyperangulated option as well. Its drawbacks are kind of the relatively small screen size, and the screen is quite reflective, so it is quite susceptible to glare, which is a bit of a risk. You can't record video on it, which is a bit of a shame. And when you use it for direct laryngoscopy, it's kind of widely recognised that its light is relatively dim compared to some of the others, and certainly compared to direct laryngoscopy. The GlideScope Go is in the middle, so that's slightly pricier. So the screen is £2,000, and that's about £25 per intubation. And the optics improve with the cost, really. So the GlideScope optics are better than the McGrath, and the CMAX obviously better than the GlideScope. One of the features of this device is that the company make kind of bespoke stylettes, which match the geometry of their hyperangulated blade, which is what's shown on the screen, which is really useful, because that should make it easier to use for the hyperangulated blades, which can potentially be more tricky. And finally, the CMAC is the most expensive. So that's the one that's shown on the right. So this is a disposable CMAC blade. So the screen that's on top is about £4,000. The imager, which is the silver part with the fibre optics that come out the bottom of it, is another £3,000. And then you're paying about £15 per blade, give or take. And the alternative is that you lose the imager and the disposable blade, and you can get a reusable blade, which again is about £4,000. So you're looking at a setup cost of about £10,000, which is obviously a significant investment for most enhanced care teams. The optics are really excellent, and you can record on it, which is obviously great for kind of clinical governance, for training and for education. But it is the cost is kind of the biggest barrier for the CMAC, I think, personally. So this slide shows a bit of a comparison of the optics between the devices. So this is obviously just on a dummy, so the air track is shown on the left-hand side. So that's the camera attachment that was shown before. And then the glide scope and the CMAC are obviously a different order of quality. And certainly the CMAC reusable blades, as I say, the optics are quite excellent. So this shows the difference in geometry between some of the blades. So these are both sold as Macintosh geometry blades. So on the left, you've got the McGrath, which, as I said, is kind of the most widely available videolaryngoscope. And on the right, you've got a Macintosh geometry blade for the glide scope. And you can see that actually the glide scope, the angles are pretty much the same as a Macintosh geometry blade. But when you look at the McGrath, it actually does have more of an acute angle. And that might actually explain why there is some reports that actually there is more of a learning curve with the McGrath than you might expect. And actually the paper that I've taken these images from, one of the things that they found in that paper was that actually their clinicians adapted to the glide scope Go a lot better, and their first pass success rate was higher with the glide scope Go versus the McGrath. And one of the things they attributed to is that actually it's because the blade geometry is much closer to what they're used to, whereas the McGrath has obviously got that kind of extra acute angle, yeah, it's a bit of a change to practice. So let's have a think about the relevant guidance and how we apply that to our own care. So this is from Safer Pre-Hospital Anaesthesia, which is the kind of current overarching guideline for pre-hospital emergency anaesthesia in the UK. And I think these are the guiding principles that I think about whenever I think about anything about emergency anaesthesia outside the hospital. So is that we should be performing to the same standards out of hospital as is provided in hospital. And that should mean that our equipment should also meet those same standards. And this is also should be seen in the light of the Difficult Airway Society guidelines. So the Difficult Airway Society provide lots of guidance around kind of managing airways in anaesthesia. And they're an eminent body in kind of UK anaesthetic practice. To be honest, these recommendations from 2015 were actually probably ahead of their time, and certainly ahead of UK anaesthetic practice as I experienced it. But we're now at a stage in hospital where videolaryngoscopy is routinely available and frequently used in emergency intubations. So emergency department and critical care intubations, you would expect most of them, in fact, I would expect almost all of them to be performed using a videolaryngoscope in my practice, certainly. And this is a piece of work done by a group of difficult airway societies from all around the world. And they've suggested that routinely using videolaryngoscopes is an approach to try and reduce the risk and prevent unrecognised esophageal intubation. Which, as we've seen before, is still a problem. Although a small number of cases, it's a catastrophic problem when it occurs. What does the evidence say? So this is a Cochrane review from 2022. So the Cochrane collaboration provided a database of systematic reviews and meta-analyses. And therefore, they're a summary of kind of all the available evidence to the date that they're produced. So this is actually an update of a previous publication, but helpfully one of the things they did in the update was they've grouped the results by the geometry of the blades. So you have to recognise that there's going to be there's differences in how the different types of blades are used and how experience affects their use. So thinking about the difference between standard Macintosh geometry blades, hyperangulated blades, and channeled blades like the air track. And there's about 23,000 patients data in this systematic review. So that's obviously massive. And what they found is that with Macintosh geometry blades, when you compare it to direct laryngoscopes, there are fewer failed intubations. That goes down even more if you have patients with difficult airway. So talking relative risk of 0.37, so less than half the number of failed intubations in patients with difficult airway. Slightly higher rates of first pass success, so relative risk of 1.05. So that's not a massive increase there. And no statistical difference in the rates of esophageal intubation. That was then replicated in the studies that had looked at hyperangulated blades versus direct laryngoscopy. So fewer failed intubations in patients with difficult airways, barely higher rates of first pass success. But they actually did find there were fewer esophageal intubations in the patients who were managed with a hyperangulated blade. Once you have to take more than one attempt at intubation, then there's no difference in the success rate between VL and DL. Unfortunately, one of the problems with this is that they can only include available data, and there's actually very few studies out there, particularly randomized studies, where have come out of the pre-hospital world. And so there's no conclusion that they were able to offer us directly as pre-hospital clinicians. So this is an important trial that wasn't included in that Cochrane collaboration paper, and that's because it's only been published in the last few months. So this is the device trial. It's an important trial because it's 1,400 patients. That's obviously quite a lot of patients, and it's performed in critically ill patients. So they're the patients that we're interested in, much more so than elective anaesthesia patients. So they compared videolaryngoscopy versus direct laryngoscopy for the first attempt, but they didn't specify kind of the device or blade that people were using either for video or for direct. Now, the only reason I mention that is because I think that is potentially important, just because in the US, they're much more likely to use straight blades in adults, which we just wouldn't do in the UK almost ever. But they did routinely use a bougie or a stylet for the first attempt. And they found that there was an improved first pass success rate with videolaryngoscopy. And there's no difference between the two groups in terms of serious complications. So thinking about things like critical hypotension, hypoxia, cardiac arrest, death, etc. And one of the things that was notable about this study was that they're relatively inexperienced intubators. So most of the intubators in this study had done between 25 and 100 intubations. So that's probably a little bit less than most of the people that are doing pre-hospital intubations. And the effect size gets less with your more experienced intubators. So the more intubations you've done previously, the less effect size there is for the use of videolaryngoscopy versus direct laryngoscopy. Interestingly, in the study, most experience within all of the intubators was with videolaryngoscopes, and that's a massive sea change from most of those studies that are included in that Cochrane collaboration review. And you did also see that the effect size about improvement that you see with videolaryngoscopy, that effect size is reduced in people who are really experienced with direct laryngoscopy. And I think that's one of the things that makes me question the external validity of this study when we compare it to our own practice in the UK. 70% first pass success rate with a direct laryngoscope is well below what we would expect. So the marker that I have in my head that I think is acceptable is about 90% first pass success rate. And actually, when you look at the highest performing services, you're looking at kind of 96 to 98% first pass success rate. So whether that's applicable to our own practice is a bit more debatable. Interestingly, when we look at the kind of complications that we expect, so we can see from the device trial and from the Cochrane collaboration publication that there's no difference to kind of significant complications by using a videolaryngoscope. But some of the complications that we would expect to see don't appear to be there either. So this is an observational study from 2017. And we're looking at the success rates of intubations in kind of soiled airways versus unsoiled airways. And yeah, as I said, this is just observational. But in VL and DL, the first pass success rate goes down significantly once you have a soiled airway versus an unsoiled airway. But overall, the rate of first pass success in soiled airways was still much higher than it is with the direct laryngoscope, which is not what we might expect given the concern for kind of video laryngoscopes being contaminated. This is more, those papers are all from kind of in-hospital settings. This is kind of more typical of what we expect from the papers around kind of pre-hospital settings. So this is a retrospective review of reported data from an electronic database in the US. So it includes 22,000 intubations after out-of-hospital cardiac arrest. So obviously you can see there's an improved first pass success rate with videolaryngoscopy versus direct laryngoscopy. But that didn't actually translate into a significant difference in ROSC rates, although there's a similar study that's been published this month, again in resuscitation, that suggests that there was a survival to discharge benefit from the use of videolaryngoscopy during cardiac arrest versus direct laryngoscopy. So that's potentially interesting. But as with device, these are studies that are performed in systems that are quite different from our own. So I'd be particularly concerned about that kind of low first pass success rate in direct laryngoscopy. And that doesn't really equate with the skills that we expect in our own practice in our own organisations. And it's concerning that the kind of repeated issue in the literature may well have affected the kind of outcome of the Cochrane review. And the other feature that kind of limits the applicability of these to our own practice is that pre-hospital practice in other countries, and even within the US, the definition of paramedic changes quite significantly. Your kind of helicopter teams in the US also look very different from the UK enhanced care service. So they're much more likely to be paramedics or flight nurses without the physician. Whereas in the UK, certainly during provision of anaesthesia in UK pre-hospital practice, we would expect there to be a physician there at all times. This is a study from a bit closer to home. So this is about the introduction of the McGrath videolaryngoscope into the MagPass air ambulance. So they ran it as a quality improvement project. And it shows that over the study period, there's no significant change in their first pass success rate. It's not on the slide, but there was also no significant change in their rates of kind of peri-intubation hypoxia, which is obviously important as well. And one of the things that they brought out from this kind of quality improvement project was the views of the team about it. So that was quite interesting. So they found it useful for training. They found it useful for shared situational awareness. But they commented that it did perform poorly in some environments, mainly in bright light. There's also unpublished data from another UK HEMS service that showed that when they introduced the McGrath videolaryngoscope, initially their first pass success rate dropped, but then recovered to its previous level as people got more used to the device. So that's probably a suggestion of a failure of training, would be my interpretation of it. So where are we currently? So these are the results of a national survey of UK HEMS services. So this was presented as a poster at the Faculty of Pre-Hospital Care conference recently. So about 2/3 of the HEMS services returned their survey, and 4/5 are carrying a videolaryngoscope. Most services use it at the discretion of the clinician. But one of the interesting things when we actually asked them about how many intubations used the videolaryngoscope, services essentially fell into two categories. Either they used it for almost all their intubations, or they used it for hardly any of their intubations, with no one really sitting in the middle. So what do I think the take-homes are from all of this? So videolaryngoscopy is it's a tool in our armory of our airway management. We've got good evidence that it's superior to direct laryngoscopes, and these devices are now widely available at every price point. There are pros and cons to every device, and you need to train on whichever device you have available. Most of the services that run into trouble with videolaryngoscopy The difficulty has been that they failed to adequately train their staff or manage the introduction of the devices. And it does require adjustment to standard practice to be used effectively. And I think that involves both training the operator, whoever that is within your service, but the operator and the airway assistant about how to use VL and how to get the most out of it and how to use it effectively. I think it's difficult in the current climate to justify, certainly in UK practice, either in hospital and enhanced care teams, it's difficult to justify not having a form of VL available. And I think the evidence would support using it as much as possible to give yourself the best chance of successful intubation the first time, which gives our patients the best chance of recovery, which is ultimately what we're all here for. So thank you all very much for your attention. I decided that I couldn't get through a presentation about pre-hospital care without a gratuitous helicopter shot. So here it is, alongside a photo of some of our new neighbours at Lincoln. So yeah, thank you very much for your attention.